learned from our research, but I'd also like to spend a little bit of time talking about our current research unit that's just newly funded and some of the objectives of that, because certainly I think there's a lot of alignment between our research unit and the Gilbray Center. So I'd really like to hear your thoughts about that as well. So I'll begin by just giving you an overview of the objectives for today. So what I'd like to do is just talk briefly about the burden of multiple chronic conditions among older home care recipients and the need for health promotion in this population. And then I'm going to briefly summarize the main findings of 4 studies that we did that evaluated the effects and costs of interprofessional nurse-led health promotion interventions for older home care recipients with multiple chronic conditions. And then finally, to summarize the lessons learned from these studies in terms of practice, policy, and future research. And then in the end, I'll talk about our research, our current research unit, and how it builds on the studies studies, which were conducted over a period of approximately 10 years. So I'm sure you guys are all familiar with these statistics. You know that Canadians over the age of 65 represent the fastest growing segment of our population. And they estimate by 2031, about 25% of the total population will be older adults. Me included over here. And we know that as the population ages, or as the total population of older adults over 65 increases, and as we see medical conditions converted from what we call life-threatening conditions to more chronic conditions, there's really an associated increase in the prevalence of chronic conditions as well as frailty. And often there's overlap between chronic conditions and frailty, so people who are frail can have chronic conditions and vice versa. So those are all included in our studies. We also know that older adults with multiple chronic conditions, represent about 1/3 of community living older adults. So when we say multiple chronic conditions, we're referring to 3 or more chronic conditions. And at the same time, we've also seen a trend toward what we call aging in place. So we see more and more people living at home in the community. So about 90% of older adults live in the community. And so the result of these trends, of course, is increasing demand for community supports to maintain people at home and to promote optimal aging at home. And when you look at older home care recipients specifically, because that's the population that we focused on in these particular studies, they have more chronic conditions, and of course that leads to poorer health status, higher use of prescription medications, higher rates of healthcare use and costs, and increased risk of adverse events, so things like death, falls, hospitalization, or premature institutionalization, or premature entry into a long-term care setting. So those are just a few. So obviously they pose a great burden to our society and to family caregivers as well. So why is this important? Well, just looking at the statistics, Canadians over the age of 65 account for about 64% of home care expenditures. So about 2/3 of the expenditures are spent by older adults, and 75 to 80% of home care users are older adults. And older adults with multiple chronic conditions account for 40% of the reported health care costs and among seniors in Canada. So that's equivalent to 13.3 million healthcare visits over 1 year. So lots and lots of funding is allocated to that. But yet we know that chronic disease can be prevented, it can be mitigated, it can be detected, and it can be managed. But unfortunately, there are multiple barriers to the delivery of effective chronic disease management, and then the sectors themselves, so for example, home care and other settings like hospital settings, are really not formally integrated. So there's lots of barriers in terms of providing effective chronic disease care, and yet there's very little research to guide the optimal way of providing these services to reduce the burden of chronic conditions. So I think all of this really points to the real urgent need to identify new ways of delivering services, particularly focusing on more of an upstream approach, looking at prevention and health promotion. Thank you, Linda. Wow. Thank you so much. That's great. Okay, so
if you just touch that, you could bring it down. The
one.
Just put it out of the way, yeah.
Move it down to,
Okay.
so you can see your face. Okay. All right, so we know we need new ways of providing services, and yet there's been a fair amount of research that's been conducted that has clearly identified that community living older adults can benefit from interprofessional nurse-led community-based interventions. And in fact, annual comprehensive visits are part of policy in some of the Scandinavian countries. So this is part of usual practice in some of the countries like Denmark, for example. And we also know that nurses can play a really key role in leading an interprofessional team in terms of promoting health and preventing frailty and chronic disease. However, the research is fairly limited and inconclusive, and there are multiple gaps. One gap is that often the research excludes people with dementia or with multiple chronic conditions. So the very people that can benefit from these interventions have been excluded from the research. There's also a number of barriers that we face in terms of providing services in the community, and there's numerous barriers, but things like delayed or limited access to professional home care services. Things like lack of interprofessional collaboration and communication, the lack of use of standardized assessment tools to identify risk factors for functional decline in chronic disease, or the lack of assessment tools that are available for them to actually use. So again, the evidence is there, but there's lots of barriers to the translation of that evidence into practice, which again points to the need for new interventions, new and innovative ways of providing care to mitigate the problem of chronic disease, and to ultimately improve the quality of life of this population, which will in essence then reduce the use of these expensive health services that are often used on a very on-demand basis. So things like emergency room and acute hospitalization. Oh, I hit the clicker, right, sorry. So to address this need, we conducted a series of 4 studies over a period of about 10 to 12 years. And the studies were unique in that they were similar in terms of their design, the population, the setting, the interventions, as well as the outcomes. So it's kind of neat because now we can sort of look across the studies and determine what did we learn as a whole from these 4 studies. So what I'm going to do is just sort of give you a brief overview of the results of these studies, which the overall aim of which was to evaluate the effectiveness of different, what I call interprofessional nurse-led, multi-component, complex, community-based interventions, and compared with usual home care among older adults receiving home care. So I'll just kind of go through them, but basically there were 4. The first one we did, which was actually part of my PhD dissertation. So when I had good results, that's a good thing because it was my PhD. And so that was looking at a general nursing health promotion intervention with frail older home care clients. And that was done in 2000-2004. We then did a study looking at falls prevention for older home care clients who were at risk for a fall. And it was an interprofessional team approach that we looked at. The third one was an interprofessional team approach to stroke rehabilitation in home care. And the fourth that we just recently completed was an interprofessional nurse-led mental health promotion intervention for older home care clients with depression. And that was targeted towards people with depression who were at risk for depression but didn't necessarily have a diagnosis of depression. So all of these populations certainly are the at-risk populations that we want to target. So if you have any questions as we go through, feel free to ask. So across the 4 studies, we had 4 common research questions. And the first was we wanted to know what the feasibility and acceptability of these newly designed interprofessional nurse-led interventions were. And secondly, we wanted to look at what is the effect of the intervention on health-related quality of life and functioning compared with usual home care. We also wanted to look at what is the effect of the intervention on chronic disease risk factors compared with usual home care. And that was quite a broad range, so we looked at some of the things I just talked about earlier, like falls, anxiety, depression, functional decline. So we looked at a broad range of risk factors. And then we wanted to look at what are the comparative costs of use of health services for the intervention compared with usual home care. And we looked at that from a societal perspective, which means we collected all costs regardless of who paid. So that's the most informative way of doing an economic evaluation because it helps to inform policy decisions. So we collected costs that were paid through the government, like OPEB, and also out-of-pocket expenditures, insurance, so we looked at all costs. And then finally, we were interested in which subgroups of clients benefited most from which approach to treatment. So the ultimate aim is to be able to target resources most effectively. So the idea is that an intervention may or may not be effective for everyone, but it may be effective for certain subgroups of people, like, for example, people who live alone or people who are over 80. So we wanted to sort of identify who were those subgroups that really benefited most from these particular interventions. Does that make sense?
Can I ask a question? In the costs, do you include caregiving costs or who do you include?
Yeah, that's a good question. We didn't formally include it, but we did ask them about if they had a caregiver and what types of things the caregiver was doing and how many hours approximately the caregiver was spending on that activity, but we didn't actually cost that out. So that's something that we probably need to look at. And simply because I think it's complicated to do that. So,
Thank you.
Good question. So we carried out all 4 of these studies through a university community research partnership. And that involved decision makers, health system decision makers, so people from the industry and from other broader healthcare organizations, and decision makers, managers, and clinicians in 5 home care programs and 11 service provider agencies across Ontario. So it was quite broad. And we used what we call an integrated knowledge translation approach, which means that we involved the partners in all phases of the research, which included identifying the problem that needed to be addressed, the research questions related to that, we work closely with them in co-designing the intervention, delivery of the intervention, and evaluation, and finally translating the results into practice, policy, and research. So they were very involved, and this is a very effective way of translating knowledge from a research project into practice. And that was our ultimate goal.
I would also suggest that it's also a very effective way of asking, for researchers, of asking the right questions.
That's right. That's right. And the problems that we identified were problems that were identified at the grassroots level by the clinician. So they weren't things that we went in and said, hey, I want to do a study on falls prevention. This was something that they had identified as a problem, and we worked collaboratively with them to identify sort of the parameters of the problem, what are your questions, and brought our research expertise with their expertise in terms of home care, et cetera, and worked collaboratively together to carry out the research. So each of the 4 studies were what we call randomized control trial. And that's where eligible and consenting participants, so people that meet the eligibility criteria for the study, are randomly assigned to either receive the intervention, the newly designed intervention, plus usual home care, or usual home care alone. And then we follow them forward in time for either 6 or 12 months, depending on the study, and measure their outcomes at follow-up to see what was the change over time in both groups, and then to compare the 2. And the interesting thing is, when we were doing the research, and I think this is still the case now, is that we really don't know even the outcomes associated with usual care. So this study, the benefit of this study was to be able to provide that data as well. So we went in saying, we're not bringing this intervention to say that it's better than what you're doing, but we just want to figure out which one works better. Is it the way you're practicing now, or is it something else? So it was really important to be able to frame it in that way. Yeah.
Could you give me an idea of, first off, 3 for the eligible sample?
Yes.
It's to be 3 problems. Can you give me an idea of that? And then what makes you ineligible?
Sure.
Okay.
Actually, that's the next slide. You're good. Okay. Yeah, I'll get to that. But just to finish off, the randomized control trial is what we call the strongest design for questioning of effectiveness, when we're looking at the effectiveness of a particular treatment. I won't go into detail today, but we did have some qualitative components to the study where we actually interviewed people to get their feedback, the providers, the people that were providing intervention, to get their feedback on the intervention and also clients and caregivers too. The predominant design was for RCT. So to answer your question, we had a total of 641 older home care recipients across the 4 studies. And these were the common eligibility criteria. So they had to be 65 years of age and over, eligible for home care services. They had to be living in the community, but not in an inpatient facility or a long-term care setting. They had to be mentally competent to give consent, or they had to have a substitute decision maker who would provide consent on their behalf. And they had to be competent in English or had an interpreter available. And does that answer your?
It does. I wondered if it had,
Yeah.
well, of course, would have to do with how disabled the
Yes.
person was, I would
So
presume.
we accepted people, that's one of the unique aspects of our studies, is that we included people regardless of the disease severity. We also included people with dementia, which sounds a bit strange because that's the population that home care serves, but what had been previously excluded in research. So we made sure. So we included all of those people in our population as much as possible.
Yeah, but you say there that the eligibility criteria was mentally competent.
Yes, and they could also have a substitute decision maker available. So if they had a family caregiver who could consent on their behalf, they were eligible. Yes. So it is a bit of a barrier because for some people they didn't have a family caregiver. So we didn't make that a criteria. So these were the common eligibility criteria. And within each of the studies, they all had really what I call like a constellation of multiple chronic conditions. And as I mentioned earlier, we had specific foci in 3 out of 4 of our studies, in that we looked at people with stroke, falls, and depression in addition to this. So I'm just giving you the broad overview of what's common amongst the 4. Does that make sense? Yeah.
Just wondering how you recruited, and maybe you have another slide coming up, or maybe
No,
you
I
don't,
can
but,
tell you, yeah.
so were some of these people just, they saw an ad and joined, or did they
No, we recruited all through the home care program.
had to go through like the CCAC?
Yeah.
Okay, so it couldn't be somebody who's just kind of, there's so many
Yeah,
people that
I
just
know.
slip through the radar.
I know,
Which we kind of talked about, I think, at the
I
last
agree.
center discussion, but how do you access those people?
So
To
they
give
had
you
to
the
be,
real deal.
yeah, they had to be eligible for
Okay.
home care.
Okay, so they were in the system.
They were in the system,
Okay,
so
thank
we
you,
trained
yeah.
out.
But of course, you were trying to measure home care, so that
Yes.
would make sense too, for
Yeah.
your recruiting. but-
Yeah, so, yeah,
I just think-
but you're right, there are a lot of people that are not eligible for home
Yeah,
care.
or whatever.
That's
Just-
right, yeah. So, in terms of the goal, the overall goal of our 4 interventions were to really look at improving older adult access to healthcare, improving their health-related quality of life, and health outcomes while reducing costs. So that was the overall goal for all 4 studies, but within each one we had specific foci. So things like reducing costs would be things like avoiding or preventing unnecessary hospitalizations, or visits to the emergency room, or admission to long-term care. So that's how we define that. So this is very broad. Do you have a question?
No.
Oh, okay, I thought you had your hand
Yeah,
up.
I'm sorry. I thought that after I started thinking about it.
So what we did was we actually developed these interventions from scratch. They were either 6 or 12 months in duration. And they were multi-component and evidence-based. And we co-designed them with the end users, so the people that were actually going to be providing it, the home care providers and their managers. And the strategies within each of these focused on risk factors for functional decline and chronic disease. So these are the common features across the 4 studies. So we had nurse RN case management. We provided an enhanced interprofessional team. So it was the nurse working in collaboration with a number of professionals. So for example, we worked with home physio, OT, personal support workers, speech language pathologists, registered dietitians, social work. I covered most of them. So all of sort of the traditional people that would be within the home care setting. And the interventions were delivered by the existing providers. So we didn't go out and hire people to give the interventions. We worked with the existing provider agencies. So the way CCAC works, as you probably are aware, is they have a contractual model of service delivery. So they do all the case management, but they contract with service delivery to the various agencies. So we recruited all of our clients through the CCAC. They were CCAC clients, but we worked with a number of community-based agencies to actually implement the intervention. So in the stroke study, we had 5 agencies that provided physio, OT, nursing, personal support for that study.
I'm wondering how you manage to randomize people in relation to the existing providers. So if I worked for a home care agency, could I be giving the nurse-led intervention some days and the regular interventions on other days? Or if I was in the study, I only had those patients?
Yeah, so what we did was we set up a system. It was complicated, but we managed to set up a system so that each agency knew who was trained. So we didn't train all of the providers in every agency, because that would be my whole career, I think, trying to do that. So we would handpick so many people, and if we knew these 5 people were on the study, we wouldn't assign them to the usual care clients. So each agency had a list of all of the clients in the study, usual care and intervention, so that they wouldn't inadvertently assign a trained provider to the usual care group. So they did that. That was an internal process, and it was very complicated.
So my just one other question is, were the care providers similar in the intervention and in the usual care?
No. Oh, you mean in terms of the trained
Their
providers?
abilities? No, their abilities. Were they the same at the beginning?
No, because we gave the trained providers additional training in terms
No,
of...
before that additional training?
Yes, they were the same. Yeah.
Okay, so you didn't, what I'm wondering is if you chose the cream of the crop to do the intervention, and therefore it wouldn't really be fair to compare them to the average nurse.
I don't think we chose the cream of the crop. I wouldn't say that. I think what we did was we took existing providers that were interested in this whole area, that were keen on research and had a fair amount of community background, because we didn't want to pick somebody who had been working in the community for a couple of years. And then we provided them with standardized training really specific to the study. So if it was the depression study, we had a standardized training manual we developed, and we trained everybody over a period of, say 3 days. And then what we did was we met with that group regularly throughout the study to provide support and mentorship.
Did you ever do any measures of the group, the nursing group who provided the care, to see that they were comparable before you started?
No, I didn't. No, it's a good question. Yeah. So it's tricky, because it was the CCAC actually that identified the provider agencies that we would be working with. And then we went to them and said, here's sort of the characteristics of the providers we'd like you to think about. And they came up with a list of 5 nurses that, these 5 nurses would be great. And then we worked with them. So everything was standardized as much as possible. And then we did sort of this ongoing training and support and mentorship. It was fairly labor intensive from the point of view of the researcher, because the one study was in Toronto, so I got to know the GO train schedule really well. Because we'd go out every month and we'd have a session with all of the people involved in providing the intervention. And they provided feedback, we provided support and mentorship, and we really created a learning environment for everyone, and shared ideas, reinforced aspects of the intervention as well. So it was quite good. So we basically came up with these ideas to sort of, they were evidence-based, these components, and they deliberately targeted all of the known barriers to providing effective chronic disease management in the community. So that was the idea that we came up, that's how we came up with these various elements. So it was based on the literature, as well as deliberately targeting some of those barriers. So we know some of the barriers in the community are that people don't work together, and there's a lack of coordination. So we looked at, we had an enhanced, going back to this, an enhanced interprofessional team, and we used very much a client and family-centered approach to care. We did monthly, the providers did monthly in-home visits, and risk factor assessment and screening, and provided multiple strategies for multiple risk factors. We had formalized mechanisms for collaboration, and we used behavioral change strategies because many of the risk factors for chronic disease require a change in behavior. So for example, in the fall study, we used motivational theory, and we trained all of the providers in that. In the stroke study, we used strengths-based practice. And in the depression study, we used problem-solving therapy. So we spent a lot of time working with them around they're enhancing their knowledge around behavioral change strategies, how to implement them and how to evaluate them. And that worked out really well. And finally, a key aspect of their role was linking and referring them to other health services. So again, this is a very high level. Due to time, I can't go into the detail for each intervention, but they've all been published, and I'd be happy to discuss that later. So just to show you that across the 4 studies, we also had a common approach to measuring health-related quality of life. We used the SF36 health survey and the SF12, which is an abbreviated version of the SF36. And we also, across the 4 studies, used a similar measure of costs, the Health and Social Service Utilization Inventory, which was developed here at McMaster by Gina Brown and Miriam Gaffney. And that, again, looks at all costs regardless of who paid. And that is both of these are self-report questionnaires. So we had interviewers separate from the intervention team who went out and did home visits and collected data on these measures at baseline and then again at either 6 or 12 months. Does that make sense? Yeah. So just getting into the results. So across the 4 studies, we found that compared with usual home care, older home care clients that were receiving the interprofessional nurse-led health promotion intervention showed greater improvements in health-related quality of life and physical and mental health functioning. And even after the cost of the intervention was added to the total cost, there was no statistically significant difference between the cost of use of health services in the usual care group and those in the interprofessional nurse-led intervention group. So in other words, both interventions cost the same, even after we added the additional cost. Yeah.
Did the patients or the clients in the nurse-led group receive more intervention? Did you
Yes,
count
they
the
did.
dose?
Yes.
Okay, so
Yes.
then you're saying although they got more, it didn't end up
That's right.
costing more because, was it offset
It
by
was offset.
decreased hospitalization or?
That's right, so
Okay.
each study was individual, so you might, the assumption is that out there is that when you add more services, it costs the system more. So we were trying to refute that and saying, if you add more services proactively and take this proactive health promotion approach, you're gonna offset the cost somewhere else, like reduce hospitalization or reduce use of the emergency room. So let's say the intervention costs $500 and you save one hospital day. A hospital day is about $1,000, maybe more, depending on where you are. So this is where we found. So in other words, they were the same. So just this is a brief, there's a lot on this slide, but I wanted to show you as a whole, looking at the other outcomes. So again, we looked at health-related quality of life and costs. Those are the common outcomes across the 4 studies. But within each of the studies, we had some other outcomes that we looked at. And what we found was, again, compared with usual home care, older home care recipients that were receiving the intervention showed a greater reduction in both the prevalence and severity of depressive symptoms in both study 1 and 4. An increase in perceived social support in study 1. A reduction in the number of falls, specifically in men who were 75 to 84 years of age with a fear of falling or a negative fall history. So in that study, we didn't find that the falls intervention was effective for everyone, but only in that subgroup. Because remember, that was one of our questions. We found in study 2, there was a reduction in the number of slips and trips. In study 4, we saw a reduction in anxiety. And then finally, in studies 1 to 4, we saw positive changes in clinical practice behaviors of the actual providers over the period of time. So things like increasing, they felt the providers that were actually involved in providing these interventions reported increased knowledge around chronic disease management, increased knowledge and use of standardized assessment tools, increased knowledge of evidence-based practice guidelines. So there were lots of other outcomes from the point of view of the home care provider. And the interesting thing is we didn't go in there with the intent of specifically capturing that, but what we saw was a real trend, a learning curve over time in that
that's
group,
great.
which was great, you know. So it was very much of a learning curve because this was a lot very different than their usual practice. And the big difference, I think, was the whole paradigm shift away from a very sort of medically based acute care paradigm to more of a focus on health promotion and prevention and more of a long-term approach. Because typically in home care, like for example, I use therapy as an example, they may or may not get multiple visits. So a stroke client might get 2 or 3 visits by a physio, whereas in our study, we're looking at a longer term approach because we know that that's more effective for people with chronic disease rather than a short-term approach. So in terms of lessons learned, overall, I think as a collective, I think these studies really add to the accumulating evidence in a Canadian context that for older adults with multiple problems, that it's no more expensive in the same year to provide services in a very proactive and comprehensive way than to provide services in a very segregated, on-demand way, which we often see. And so we found in this study that in these studies, proactive, comprehensive, and integrated interventions were both more effective and no more expensive than usual home care in the same year. And we also found from the feedback from the providers and clients and caregivers that were involved in the studies that it was the approach for that from their perspective was feasible. It could be easily integrated into practice, and it was acceptable from their point of view. So these are all important things to consider when we're trying to integrate any kind of an intervention into usual practice. It has to be feasible, and it has to be acceptable, both to the people who are providing it as well as the people who are receiving it. So really, what we did this was all under what I call real world. So this was the real world, and so it wasn't like an experiment in a lab, that we were actually doing this under the usual home care system, which actually changed quite rapidly throughout those 10, 12 years in terms of policy and practice and agencies and so on. So it was challenging. So this is a busy slide, but basically when we did our economic evaluation, we used Stephen Birch and Maureen Gaffney's work, which originates here at McMaster, who are both health economists. And when you think of economic evaluation, it consists of sort of a comparative analysis of the costs and consequences of different courses of action. And the assumption is we have a fixed pool of available resources. We don't have an unlimited supply of resources. So the question is, how do you best allocate resources within that fixed pool? So across the studies, we classified the main effects and costs of these interventions with the goal of maximizing improvements in health using a fixed pool of resources. So if you look at this diagram, you can see that there are 9 possible outcomes. So the more favorable outcomes are in the triangle.
The little red dot is a laser.
Oh, is it? Oh, perfect. Okay. So these are the more favorable outcomes in this diagram, and I don't think you have to be a brain surgeon to figure that out. So you see the no-brainer is where you see an increased effects at reduced costs. That's what I call a no-brainer, because that's what you want. What we found was increased effects in terms of health-related quality of life, reduction in risk factors, at no additional cost or the same cost. And then here you see this is what they call cost effectiveness, where you see increased costs, increased effects at increased cost. So this is where you want to land, is in this diagram, triangle here. And some of the other, this is where we often see people land, is where you introduce programs that actually are not very effective. So this just gives you a pictorial overview of where our studies were mapped in terms of this economic framework. Does that make sense? It's a busy slide. So I think the other lesson learned is that the allocation of home care services, it has largely been based on physical needs or medical needs, on the apparent assumption that other determinants of health are not important or don't need to be addressed. So I think on the contrary, our studies have really demonstrated that comprehensive approaches and coordinated services that are aimed at all of these determinants of health are superior as opposed to focusing on specific things. And this was another paradigm shift that we need to work on with the interventions, is trying to get them to think about all of those dimensions of health simultaneously and how they interacted. So we had things like standardized forms that they used that triggered their assessment in all of those various areas. Certainly the studies really extend and support the literature around best practices regarding successful community-based health promotion interventions. So things like intensive case management and community navigation became important. Enhanced interprofessional teams to promote integration and coordination of care across providers, across agencies, and across sectors. Person and family-centered approaches. Regular in-home visits were very important to address many of the barriers people face in terms of accessing healthcare. And risk factors assessment using standardized tools. And I think the other thing we learned was that support, it must be delivered over a longer period of time, and that you need consistent management to facilitate those processes, as opposed to more of an acute medical model where there's short-term receipt or delivery of services. We also found that effective programs include evidence-based strategies for chronic disease management and behavioral change strategies. Early access to appropriate services, so identifying services, a need for services earlier and then initiating that. Referral to communities and coordination of community services and family caregiver assessment and support. And I can't say enough about that last bullet, because one of the things in home care is that in order to be eligible for home care, you yourself have to have a need as a client, but the needs of the family caregiver aren't really factored into that. So what we tried to advocate as much as possible is we had a very family-centered approach in our interventions. So it wasn't just focusing on the client, it was also looking at the caregiver and their needs. And so that was really, really important, because we know about 80% of the care in the community is provided by family caregivers as opposed to formal caregivers. So they bear the load. And finally, we also found we know successful interventions need to be tailored to individual needs, and that the most expensive services are those that are not. So when there's a disconnect between needs and services, that's where we see increased cost or people's needs not being met effectively, and there's a reduction in their health-related quality of life. I think the other thing we learned is that no single intervention or mix of services can address the needs of all people. So it needs to be very much tailored to that individual's needs, and the interventions need to be adapted and tailored to the local setting. Because the greatest cost savings can accrue from those people who are high users, and certainly we focused on that group. And so I think there's a need going forward to always consider who with what characteristics benefits most from which approach. Because the reality is we only have so many resources and we need to target them very, very effectively. So I think the other big challenge was and the lessons learned was that successful translation of these interventions requires changes in attitudes and behaviors at multiple levels. So older adults and their families is the first level. So for example, people don't often accept the fact or see that they're at risk for depression or falls. So there are multiple barriers there, and they may not be ready to implement changes in their practice or in their environment or their behavior. Healthcare providers, certainly it involves changes in practice behavior and addressing all of those, like their knowledge level, and build in mechanisms to really support the change in practice, and that's really, really important. Organizational changes needed to occur in order to integrate these interventions into practice, and having executive directors of the agencies involved and having their support was really, really critical to support those changes on an ongoing basis. And I think policies and standards that support the delivery of health promotion and the allocation of adequate resources for assessment of risk and the delivery of these health promotion strategies is really, really important. So you can see it's very multifactorial, and that we need to be thinking about this when we're designing health promotion interventions, and we need to be targeting all of these various areas. So I think what we learned overall is that home care really has the potential to play a key role in chronic disease, in mitigating chronic disease and its adverse outcomes, and that we found across our studies that these proactive, comprehensive approaches are much more effective in improving health than on-demand segregated services. And that these types of services that address single problems and single issues. And that really there's a need to reinvest dollars into this approach. So what we're not asking for extra money. What we're asking is to reorganize services in a way that can address people's needs more effectively through these approaches. So So, I think there's certainly a need for a paradigm shift away from what I call a find it and fix it episodic approach to a find it, manage it, and prevent it approach. And I think really making strategic investments now will help to mitigate the risk factors for chronic disease and loss of independence to really promote people's ability to live at home, even with significant challenges. And I think the key to a well-planned system is that it addresses the evolving healthcare needs of this vulnerable sector of the population. And I think making these investments will certainly address that. So I just wanted to acknowledge the funders for all of these various studies. So we had a number of people, and we also had in-kind support from the community agencies that were involved in the particular studies as well. So we're very, very fortunate to have that too. So I'm not sure if you're going to make this available afterwards, Amanda, but each of the studies have been published except the depression one. I've submitted the final report and I'm just writing a manuscript, but the protocol has been published, so if you're interested, I can either send you the final report or the protocol as well. So if you want more detail on each of the individual studies, it's all in there. So I'll just stop now and ask if anyone has any questions about our current research, and then I'll just briefly talk about our research unit.
Great, thanks. I think it was a really good, a lot of data there, and
I know.
a very comprehensive research study to help challenge some of the assumptions
Yes.
About the costs in healthcare and home
Okay.
care more specifically.
Yeah.
Thank you. Question?
Thank you, I really enjoyed it. I'm wondering, you mentioned that you had specific formal arrangements for interprofessional collaboration.
Yes.
And I'm wondering if you could explain that a little more.
Sure. So there were a number actually. So in studies 2, 3, and 4, part of the intervention involved a case conference, a face-to-face case conference with all of the home care providers in one room, where they would bring the findings from their assessment, share those, and collaboratively develop a plan of care, client-centered plan of care. So they would meet every month to do that. And they also all had similar assessment tools. So for example, in the stroke study, we used the dimensions of community reintegration as our framework. So all of the providers used the same framework, and again, that was to trigger assessment of all the determinants of health. So when they came to the meeting, they had all came with that same sort of framework in mind and shared their ideas back and forth and developed a plan of care. That was one piece. The other was we had developed some formal mechanisms whereby the home care case manager would communicate with the family physician. Because as you know, the family physician is not present in the team meetings, or that just isn't feasible. So we had what we call alerts as one example, where for example, in our depression study, if there were concerns about a person in terms of their depression, dementia, or delirium, we actually had like a fact sheet that they could complete, and they'd either call the physician or fax it to the physician and ask them, alert the physician, if this is a problem, can you please arrange for follow-up, with the client's permission, of course. So that was another mechanism that we used. And we did all of the training and meetings collaboratively and worked together. So we really worked hard on trying to get the teams working together. So we provided training to the RN care coordinator in terms of carrying out a team meeting and helping her with that whole piece, and doing some workshops with the team around collaboration into professional care.
Thank you.
So there were lots of things we did. Yeah. Does anyone have any other questions?
I have a quick
Sure.
question on how you talked about the consciousness raising, let's say, I'll
Yes,
call it that,
yeah.
right? So I mean, that had an effect, participating in the research. How do you think that those who didn't participate felt about the fact that there's maybe, like you're saying, there were more interventions happening, right? Were there any comments from the larger
You mean
group of
providers?
service providers?
Yes, they actually, a lot of them wanted to be part of the study. So, yeah, it was and it was interesting because when each study ended, they didn't want to leave. And the other thing we saw too was a lot of transferability of some of the skills to other client populations. So they said, gee, I never did think about about the issue of depression as being such a big issue. So now when I'm out visiting, I'm thinking about that, I'm more aware of that as a problem and issue. Or I never saw the value in using a standardized tool, and now I'm seeing that. So there was a lot of transferability of skills across providers and settings, which we weren't able to measure, but it would be really cool to be able to see how that had an impact on the agency as a whole.
Right.
But, you know, it's certainly something that they all benefited from.
Thanks.
So I'll just move on and briefly talk about our current research unit. And I think the lessons learned from our research to our current research program. And I think we learned a lot from the previous studies to be able to build on that. And so recently we were funded for the development of a new research unit here at McMaster called the Aging Community and Health Research Unit. We're still in our early phases. In fact, we just moved a little while ago, so I just finished unpacking. So, but the overall goal of the unit is to promote optimal aging at home for older adults with multiple chronic conditions and to support their family caregivers. So to this end, similar to our previous research, our plan is to design, evaluate, and translate new and innovative community-based interventions to ultimately improve quality of life, access to health care, health outcomes in this population while reducing costs. So that's our overall goal for our research program. So this is a 5-year program of research, and it's funded through, supported by over $6 million in funding, which is funded through the CIHR Community-Based Primary Health Care Signature Initiative, the Ministry of Health Health System Research Fund Program Award, and also through the CIHR Canada Research Chair Program. So what I'm going to do is I'm just going to give you an overview of the 7 studies that we've planned in the context of our research program. So the research program will involve conducting 7 studies over a period of 5 years, and primarily in Ontario and Alberta, and 5 knowledge translation events. So I'll talk about those in a minute. And the team consists of an experienced team of interdisciplinary researchers. So we have 30 co-investigators and decision makers involved in our research. And we have Deborah Bournes, our provincial chief nursing officer, as our principal decision maker applicant. And I'm co-leading this research program with Jenny Clough. And we have over 25 collaborators from various community agencies and patient groups as well. And so we have 7 studies, and these 4 studies are the ones that we're currently conducting in our first year. So these studies are foundational and will help to inform the next phase, which are 3 intervention studies, which I'm going to talk about in a minute. So in our first study, we're looking at the experiences of older adults, formal caregivers, and family caregivers in managing multiple chronic conditions in the community. The second one is looking at the correlates, health outcomes, and costs of multiple chronic conditions. And the first one, just to go back, is a qualitative study. The second one, we're using data, secondary analysis of data from ICES and the Canadian Community Health Survey.
I was just wondering if your population is still home care recipients,
No,
or if it's now broader.
it's broader, yes.
Okay.
Yes, I've moved on to that. It
Okay.
includes
No,
home
just because
care.
many
No,
people aren't in the home
That's
care
right.
system, so
Absolutely.
it's good to know that it works there, but then there's all these other people
I know.
who need care.
Some are in home care and some aren't. So
Okay.
these particular studies are all in the general population of
Okay.
community population of older adults, 65 years of age and over, with multiple chronic conditions living in the community. So similar to my previous research. Does that make sense? That's a good
Yeah.
question. Third study is a sex and gender-based analysis of family caregivers of older adults with multiple chronic conditions. And the fourth one, we're actually designing a mobile health application to support the delivery of evidence-based stroke care at the point of care. So we're working with IdeaWorks at Mohawk College to co-design this app with the end users. So we've done a number of interviews with home care providers and patients, caregivers, to find out where are the gaps in stroke care in the community, and then using that information to inform the design of the features of the app. So these 4 studies will give us a sense of the burden of multiple chronic conditions in the community, the determinants associated with those chronic conditions, and that will all help to inform the 3 intervention studies. So we've designed 3 intervention studies, and these will start next year in year 2. So it's a very ambitious program because our funding from the ministry is 3 years, and our funding from CIHR is 5. So all of the Ontario sites will have to be completed in 3 years, whereas the Alberta ones are 5. So if you see me running through the hallway, you can understand it.
With your running shoes.
Yes, that's the one. So those 4 foundational studies will help to further inform and tailor these 3 intervention studies, which will be conducted in both Ontario and Alberta. And the first one is the evaluation of a transition intervention for caregivers of persons with dementia and multiple chronic conditions. So just to go back to Linda, what you were saying, I should clarify. We are looking at community-based people in the community with multiple chronic conditions, but we are specifically focusing on 3 index conditions within the context of multiple chronic conditions, and those are dementia, diabetes, and stroke. So in the 4 previous studies, we're specifically looking at those things in the context of multiple chronic conditions to help with these 3. So you can see we're looking at first, in study 5, we're looking at dementia, and 6, we're looking at diabetes, and final one is stroke.
How did you pick those? Like, what about arthritis or?
They're the ones that most commonly are the most prevalent, and the ones that most commonly co-occur. And they were also the ones that built on previous work that we had done.
Okay.
So for example, in study 5, that we had done, Wendy Dukelby had done a fair amount of work in developing a transition toolkit and doing a pilot study. And so we were just building on that work in this study. In study 6, as you know, I have funding through the LaBarge initiative here at McMaster, and we're currently conducting a pilot study to look at the self-management strategy for older adults with type 2 diabetes and in the context of multiple chronic conditions. So that study will help to inform this one as well. And study 7, which is a community navigation and rehab intervention for stroke survivors, is based on a pilot study that I did, the one that I just talked about. So it's building on that as well. So those are the main studies, and just wanted to mention that in addition to that, we're doing, in addition to the 7 studies, we'll be doing 5 knowledge translation events, which will involve bringing together all of the researchers, the collaborators, the decision makers from the various areas, and talking about the findings and having a sort of a discussion about what do those findings mean in terms of practice and policy, and then what does it mean in terms of further tailoring the intervention. And we're also, a big objective of our research unit is training. So training undergraduate, graduate students, postdocs, and new investigators, as well as training the health professionals that are involved in the study. So really building research capacity in a broader sense, not just research capacity in terms of students, but also research capacity in the home care setting. And then, as I mentioned, the KT events. So that's sort of an overview of the program.
Can I just ask, for your 5 integrated knowledge translation events, are you also going to be doing things like fact sheets
Yes,
for
we
practitioner,
are.
for policymakers?
Yes, we are. So we are going to be doing all of those above as well. So this is more, when I say integrate, these 5 events are actually like a workshop where we bring people together for like 2 or 3 days and present the results and have some discussion as a group. So that's sort of an overview of the research unit. So I'm just wondering if anyone has any comments or questions. And again, we're really new. This is a
Very
fun-
ambitious and impressive.
Yeah. So it's pretty exciting. And we're very, very fortunate to have funding. So
Where's the unit officially housed?
well,
Is it
right
in-
now we're in 3 and 25, and we also have some space down the hall as well. So we're quickly outgrowing our unit. We just moved there, so we're upstairs on the 3rd floor in Hillside. So we hope to have